Pediatric Vfib Vtach policy 53033. Okay, so let's talk about the first things we want to do in this policy. BSI scene secure. Check your patient. Hey patient, are you okay? Check for a pulse. I don't feel a pulse. Check for breathing. Is he breathing? If it's unwitnessed, do compressions for 2 minutes. Probably faster than that. Faster. Go ahead and attach your pads, assuming other people are around to continue compressions. And check out your rhythm. Let's see, what do we got? Oh, I think that's Vfib. Okay, you got Vfib. That means we need a shock. You're gonna shock 2 joules per kilo. Do the math. Clear, and there you go. Okay, now we want to give some epi, so we should work on a line. Try to get an IV if you can. If not, let's go for an IO. Oh, there's my IO. Perfect. Okay, now we're going to give some epi. You're going to give 0.01 milligram per kilogram, 1 to 10,000. Don't forget, compressions are still going for 2 minutes, and make sure you have a BLS airway intact. And of course, after 2 minutes, you can do another pulse check, and you still got Vfib. So you're going to shock again, 4 joules per kilo this time. Clear, and there you go. Now we're going to continue CPR, and your next drug is amiodarone. You're going to give 5 milligrams per kilogram on amiodarone, and another 2 minutes of CPR. Now the same applies for this rhythm, Vtach. Same drugs, epi and amio. Same shocks advised. Your max dose for amiodarone is going to be 300 milligrams. If you get ROSC, you're going to give 5 milligrams per kilogram over 10 minutes. Don't forget to transport and do a call-in. While working the code, you want to make sure you're doing a really good pediatric primary survey. Policy 53032. I didn't mean to choose such dramatic music, but let's just go with it. Okay. First, we need to evaluate our airway and look for signs of obstruction or hypoxia, cyanosis, respiratory distress, choking. Look for chest rise. Do lung sounds. Consider toxins. Is this a possible overdose? We're going to open the airway and suction if we need to. Place a BLS airway like an OPA. Do a head tilt chin lift, or jaw thrust, if in the setting of trauma. Assist ventilations at about 20 breaths a minute. Evaluate circulation. Single rescuer CPR should be 30 to 2, and 2 rescuer CPR should be 15 to 2. Do an environmental assessment, which includes considering intentional injury. Don't forget to utilize the Broslow tape if needed. If they're longer than the Broslow tape, use adult protocols. Obviously, in an emergency, it's going to be really hard to get our patient's weight in kilos, so there's a formula we can use to estimate. So this is the formula for a patient less than 1 year old. You'll have your age in months divided by 2, plus 4, and that's going to be your kilos. As an example, you have a 6-month-old baby divided by 2 plus 4, 3 plus 4 equals 7 kilos. That's approximately 15 pounds. That should be your average. And there's another useful formula for patients greater than 1 year old. It's going to be the age in years. You're going to multiply that by 2, add 10, and that should be your weight in kilos. Okay, let's do an example. So you have a, let's say, 3-year-old patient. Okay, so we are putting this into the formula. You're going to, let's change colors, multiply that by 2, parentheses, add 10 kilos. Of course, we're doing this really quickly in our head because obviously family's screaming and we're trying to figure out how to give them meds. So 3 times 2 is 6. Add 10, you have 16 kilos. And yeah, that's approximately, 35 pounds. That's your average 3-year-old. Now, if we have these formulas memorized, it's going to make everything a lot easier when we're trying to give meds in a code. So you have 0.16 milligrams, 1 to 10,000 of epi. Now we're giving 80 milligrams of amiodarone for this 3-year-old, hypothetically. And for defibrillating, we're going to shock at 32 joules, and the second shock will be at 64 joules. So yeah, simplified. Okay, so our next protocol is going to be shock non-traumatic. Policy 53021. Okay, we're going to start with our ABCs. Airway, protect the airway, oxygen, high flow. Refer to policy 53002. In non-traumatic shock, there is inadequate tissue perfusion. It could be from an internal injury or sepsis or dysrhythmia. Oh my God, I'm so sorry. Apparently my neighbors want to blow off illegal fireworks. We're going to put the patient on the monitor and transport rapidly. You're going to want to establish a line and give LR standard tubing. 1 or 2 IVs, run wide open. Remember, if their systolic pressure is under 80, you can give 2 bags of LR. And if it's between 80 and 100, you can give 1 fluid challenge. And if more is needed, you can contact base. Okay, so now you're also going to want to do a 12 lead, because remember, these patients won't complain of chest pain, but it doesn't mean that something isn't going on, that there's not an important dysrhythmia that we need to figure out. So run your 12 lead and figure out appropriate patient destination from there. Of course, do a call in, and you could actually ask for base hospital orders for an epi drip if needed. Don't forget to assess lung sounds before and after administering fluids, and double check for pedal edema so you don't give too much. So some signs of shock are decreased mental status, diaphoresis, tachycardia, and possibly a low BP. Wet lung sounds can indicate CHF. Dry lung sounds can indicate PE, like from women who take birth control. Also pericardial tamponade and tension pneumo. There's our call-in, do your appropriate call-in. Dry lungs and flat neck veins, those are our sepsis patients. Vomiting, diarrhea, fever, GI bleeding, trauma. Consider hypovolemia in those cases. There's our lung sounds.